for any reason, please call right back and we will continue. Second, please locate the chat box in the bottom left-hand corner of your screen. If you have any questions, type them in the chat box and we will address those questions throughout and at the end of the presentation. Lastly, if you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar has ended or in a post-webinar email. All CEUs will be mailed out within the next week. Before we officially begin, I'd like to provide a little disclaimer. Immunization Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to the benefit of the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd now like to turn it over to our speaker, Dr. Devin Grayson, who is the Assistant Professor of Health Communication at the University of Massachusetts. Devin Grayson, PhD, studies the interactions between public health interventions and the way people use information in their everyday lives. A social scientist, Dr. Grayson has led and collaborated on a variety of studies about vaccine hesitancy and confidence, including ethnographic investigations of under-vaccinated communities, qualitative work with healthcare providers and vaccine-hesitant parents, and surveys about immunization policies, practices, and intentions. Current work focuses on barriers and facilitators to vaccination, cannabis use decision-making in pregnancy and lactation, and online health information sharing. Welcome, Dr. Grayson.
Thank you, Brianne. It's a pleasure to be able to speak with you all today from my home in western Massachusetts on the ancestral and unceded homelands of the Pocumtuck and Nonotuck peoples. Before I begin, I'd like to acknowledge that the research that I'll be presenting in this webinar was conducted on the traditional ancestral and unceded lands of the Musqueam, Squamish, and Tsleil-Waututh, as well as that of the Lekwungen-speaking peoples, the Songhees, Esquimalt, and Wasanich. And to locate this presentation a little further, I'd like to make the following disclosures. I do not have any affiliations, financial or otherwise, with any pharmaceutical, medical device, or communication organization. I do not intend to make therapeutic recommendations for medications, and the research that I'll be presenting here today has been funded by public government sources. The agenda for the webinar today will cover first a bit about vaccine hesitancy and the ways that it is a multidimensional issue. Second, the importance of and some methods for understanding hesitancy in context, and I'll use examples from a suite of studies that I've done in British Columbia. And finally, we'll talk about crafting messages that resonate and techniques to build confidence in specific contexts. It will come as no surprise to anyone working in public health that some people today have doubts and concerns about the safety and effectiveness of vaccines. Attention-grabbing headlines such as these are pervasive across multiple forms of media these days. Vaccine hesitancy is a term used to refer to delay in acceptance or refusal of vaccines despite the availability of vaccine services. Hesitancy is complex and it's context-specific. It varies across time, place, and vaccine. Hesitancy is influenced by such factors as complacency. Some people may think vaccines are no longer needed for diseases that have become rare or for diseases they perceive as non-serious. Also, convenience. Barriers to obtaining vaccination make it more likely that doubts and concerns will delay or prevent vaccination. And finally, confidence, a lack of trust in the safety or effectiveness of vaccines, which unsurprisingly affects a person's intentions to get themselves or their child vaccinated. Hesitancy about vaccines is as old as vaccination. People have had doubts and concerns since Jenner first scraped cowpox blisters and inoculated people against smallpox. Although the specific doubts and concerns evolve over time. As old ones wane, new ones tend to crop up, making vaccine confidence something that must be continually shored up. Although the idea that cowpox might turn people into cows is good for a laugh today, vaccine hesitancy remains a serious issue, as vaccine refusal has been associated with several recent outbreaks, including pertussis in the UK, US, and Japan, and measles in the USA, Canada, Israel, Thailand, and across Europe, particularly in the Ukraine, as well as Italy, Greece, Georgia, Russia, Serbia, and France. Refusal and related outbreaks have also been associated with death. For example, the WHO European region recently reported a total of 83,540 measles cases and 74 deaths for 2018 in Europe. Excuse me. And the US CDC reported over 13,000 pertussis cases and 10 deaths from pertussis in 2018. It's important to keep in mind that 80% of people or more do get all vaccines, and it's only about 2 to 3% that are firmly committed to non-vaccination. So where is our hesitancy problem? It comes into play in two different ways. First, the people who are unsure and don't vaccinate because that seems more cautious to them. And second, the people who do vaccinate but have substantial concerns, who are then at risk of stopping if they have a negative vaccine experience or receive anti-vaccine propaganda. Hesitancy is often conceptualized as a spectrum, and the population distribution along the spectrum makes a bit of a pyramid. And at the top, we have the refusers, the 2 to 3% who are fairly committed against vaccination. This population tends to be characterized by being strong-willed and committed against vaccines. They often have what they feel is a natural approach to health and/or religious or moral consideration. Below those committed refusers, we have partial refusers, who make up maybe about 15 to 20% of the population. And these are those with significant doubts about the safety and necessity of vaccines, and who are often actively seeking information and have conflicting feelings on whom to trust. They may be strongly influenced by social networks. These next two groups down are also hesitant, but typically get all vaccinations on time. They may show a strong focus on understanding vaccine risks. They exhibit complacency, perceiving the benefits of vaccination to be low. These folks with some concerns could easily move up or down this continuum due to various influences. For example, advice from a healthcare provider, a local outbreak of a vaccine-preventable disease, or experiencing what they think might be an adverse event following vaccination. Finally, the largest population group making up the base of the pyramid is the acceptors. They consider vaccines to be important and safe, trust their healthcare providers, and are influenced by social norms to vaccinate. When people think of vaccine hesitancy, they often get an image of the typical non-vaccinating mother in their mind. Picture her for yourself now. If you live in the US, it's likely that she looks something like this. Media narratives have played up certain images of non-vaccinators, but this only tells part of the story. And such stereotypes can do a disservice to our understanding of the whole phenomenon of vaccine hesitancy. In reality, hesitancy comes in many forms and flavors among many communities and cultural groups. Not all hesitancy is the same. And because hesitancy occurs in a variety of settings and among diverse populations, understanding what kind of barriers to vaccination an undervaccinated community is experiencing is important to being able to effectively reach them with confidence-building vaccine messaging. Implementation science has shown us that context matters to how effective interventions are. Over and over again, we hear this. The same thing that might build vaccine confidence in Florida might not work the same way in Utah. And the reasons people in Wheeling, West Virginia don't get vaccinated may or may not be the same reasons people in Las Vegas don't get vaccinated. Therefore, we now turn to part 2, understanding hesitancy in context. And we'll use the Western Canadian province of British Columbia as a case study. Why British Columbia? Because British Columbia, or BC, is home to the Vaccine Evaluation Centre, which is the oldest and most established pediatric vaccine research center in Canada. It's been around for over 30 years, conducting hundreds of vaccine studies across the spectrum from immunological bench science to clinical trials and vaccine safety surveillance to the social aspects of vaccination. And I spent 3 years there as a social scientist embedded in the Vaccine Evaluation Center at the BC Children's Hospital, working to better understand how vaccine hesitancy and confidence works in that context, and what interventions would be most likely to succeed in building confidence. So a geography moment. British Columbia is the southwesternmost Canadian province, and as you can see, it covers a very large geographic area bordering on Montana, Idaho, Washington, and Alaska. As with many large provinces and states, the majority of the population is concentrated in a few urban areas, which in British Columbia are within 100 miles of the southern U.S. border. British Columbia is home to the third largest metropolitan area in Canada, which is similar in many ways to Seattle, as well as to rural and remote communities only accessible by boat or plane. Like all our states and provinces, BC is unique, but it's not just that BC is different from other states and provinces. BC is also different from BC as well. And it's important to acknowledge the diversity of context, settings, and peoples even within the geographic borders of a state, province, or health region. When people think of British Columbia, they often think of this, and maybe with a little bit of this. But many people's everyday British Columbia really looks a lot more like this. And some people's looks more like this, or like this, or this. And some people's everyday BC really looks quite a bit like this. And in understanding how setting and other elements of context affect vaccine hesitancy and confidence, we must therefore consider, first, how is this region similar to and different from other places? And second, how might this affect vaccine attitudes? I'd like to ask you to just take a moment now and consider, who do you think are the and under-vaccinated groups in your community? And in what ways is this community similar and different from other communities in your state or in the country? Along with colleagues at the University of British Columbia, the Center for Disease Control, and members of a national immunization research network, as well as US-based colleagues, I've studied the context-specific ways vaccine hesitancy and confidence occurred. And this work largely fell into three baskets: studies of parents, of providers, and of policy. So first and most prominently are the parent studies. Demographic and cultural differences abound within BC as well as between the province and other jurisdictions. In several ways, parents in BC may more strongly share cultural and demographic characteristics with other Pacific Northwesterners than, say, Eastern or Atlantic Canadians. In order to piece together a good picture of vaccine attitudes among the BC parents, we've conducted surveys and focus groups with pregnant women and new mothers about flu shots, a longitudinal study following mothers and fathers from pregnancy through their child's toddlerhood, ethnographic research with mothers of infants under 6 months old in a region that was identified as undervaccinated, interviews with mothers of children up to 6 years sampling across the hesitancy spectrum, and interviews with mothers of primary school children who had changed their minds, which is to say that either started out vaccinating and then stopped for some reason, or started out as non-vaccinators and then at some point in early childhood decided to start for some reason. We've also conducted a suite of studies of healthcare providers. While the health system overall in Canada is publicly funded, which is different from most U.S. healthcare, providers such as doctors, nurse practitioners, and midwives primarily work in private practices, which in the area of vaccination are complemented by a workforce of government-employed public health nurses. So in this suite of studies, we focused on interviews with family doctors and nurses who vaccinate young children, surveys and interviews with registered midwives, and interviews and ethnographic research with a variety of maternity care providers. And finally, we've done some policy studies because we're interested in exploring what policy levers could be useful and acceptable to this specific population. So we've conducted a survey of the public and parents' attitudes about policies such as school mandates to increase childhood vaccination, and analyses of policies and how they've worked or not in different contexts around the world. And across all three of those baskets of study, a key finding that resonates across all of them is that trust matters. To reach hesitant parents with messages that will be received as credible and actionable, you need to understand whom they trust, what they don't trust, and why. Evidence indicates that hesitant populations don't always conform to the stereotypes or conventional wisdom about vaccine hesitancy. There's common ground in that virtually all parents want to keep their children safe and healthy, and most these days feel a responsibility to be educated about health decisions. But in British Columbia, for example, we heard fewer parents expressing concern these days about measles, mumps, rubella, or MMR vaccine than in some other places, suggesting that the message had gotten out in that region about the lack of a link between MMR and autism. Breaking this down further, let's examine some key themes that emerged that hold lessons that may be transferable to other locations about how to build trust in vaccination. One thing we heard loud and clear is that parents trust their regular healthcare providers. But some don't have a regular family doctor or medical home, and that poses a challenge to building a trusted healthcare provider relationship. Also, what's considered to be alternative elsewhere might be mainstream on the West Coast, for example, home birth or traditional Chinese medicine. And this is true in some other regions, but not all. So it's worth considering, what are the trusted healthcare providers in your region? A second finding was that parents' vaccine concerns are often science-based, even if the information that they have is incomplete or is not up to date. For example, many parents expressed hesitancy about vaccines that they perceive to be newer. This reflects sound scientific principles, and we can actually be a bit pleased that this portion of the public has gotten the message that older therapies generally have longer safety records. However, we need to update parents as the evidence evolves. For example, the human papillomavirus vaccine, HPV vaccine, is no longer new, and in fact appears to have a very strong safety and effectiveness record at this point. One thing we found when we studied parents who had changed their minds about vaccines was that families who fall through the cracks are at risk for vaccine hesitancy and non-vaccination. This sometimes happened when a child or family health issue arose, launching the family into medical uncertainty and shuttling them among specialists. And this seemed particularly germane in cases with difficult diagnoses, such as autoimmune disorders, developmental delays, or gastrointestinal diseases, which can take a long time to fully diagnose and develop a treatment plan. So here's one example. One family had stopped vaccinating when their first child was a toddler and developed a mysterious autoimmune condition. At that time, their family doctors suggested that they temporarily delay the next round of vaccines until that health issue was resolved. 10 years later, we interviewed them. That child is still not fully diagnosed, and both that child and a younger sibling that has been born in the meantime have not received any vaccines. The family felt like they were following their doctor's advice, but they had been launched into a world of medical specialists who didn't follow up on routine things such as vaccination. The more fragmented the healthcare system, the more likely this kind of thing is to occur as people lose or lack regular contact with their trusted primary healthcare providers. Another topic that emerged was that fathers may be more involved in co-parenting in British Columbia than in some other settings. And particularly, this may be changing generationally in many places. While in some families, mothers retain the traditional role of child caregiver and child health decision maker, many contemporary families are dedicated to shared co-parenting and may also have diverse family structures, including blended families and multi-generational families with multiple adult decision makers, same-sex parents, and increasingly fathers taking on substantial amounts of child caregiving, including sometimes as sole or primary caregiver. However, fathers and co-parents are often overlooked in outreach by public health and clinicians alike. Because mom is usually who takes the child to a medical appointment, it's frequently assumed that she is the primary decision maker about vaccines. An outreach to men and GLBTQ communities could help allay hesitancy and shore up vaccine support among fathers and co-parents. So I'd like to pause for a moment and put the question to you again. When you think about the un- and under-vaccinated groups in your community, What are their trusted information sources? What do you know about the needs, values, and trusted information sources for undervaccinated members of your community? I'm going to shift now to the next section, which is looking at, based on these findings, what can we learn about crafting messages that resonate and ways to communicate that may build confidence with individuals and communities who are unvaccinated or undervaccinated? One thing we learned was that British Columbians were very pro-social, which is to say that they care about the good of the community, not just themselves or their immediate family. Therefore, a strong strategy in that setting is to emphasize that vaccination isn't just for the person getting the shot, but to protect the vulnerable community members, such as infants, elders, people with cancer, etc. Messages that leverage this pro-social value are things like, you shovel your elderly neighbor's sidewalk. Will you also roll up your sleeve to protect her from the flu? Or, oh, you babysit for your infant niece. Would you also get a shot to protect her from influenza? This kind of message resonates well in a lot of settings, but not necessarily in all. The scale or the focus might need to differ depending on the community that you wish to reach. For example, in a community where there is suspicion of literal neighbors, but there are strong religious communities, encouraging members of the public to protect the elders in their church, for example, might resonate. And particularly, and I'll get to this point a little later, if you can partner with a community leader to deliver that message. I wish I had more great visual examples that I could share of this strategy in action. Most of the examples that I've seen are highly localized, using pictures of cute children with cancer that are in your school, or focusing on protecting one's own newborn. I think we could do a lot more with this approach, especially if we dovetail it with some of the other strategies I'm about to highlight. And here are a few examples. There's one from Australia here, but some of the examples that have been used, particularly in school and religious communities, that have pictures of community members that one might recognize and feel a personal pull to protect, have been very effective. Another thing we learned is that many parents, those who are vaccine hesitant in BC, were very science-oriented. So we risk offending them or alienating them if we dismiss their concerns as anti-science or ignorant. To respond to this, it's important to have at the ready good scientific answers to common vaccine questions, such as, why is our hepatitis B schedule different from this schedule from another place? Who is actually supposed to get the flu shot? Is it everybody? Is it just high-risk people? What kind of long-term follow-up has been done with the HPV vaccine? You can't anticipate every question parents will have. So you also have to consider, if you don't have a ready response to a parental concern, what is your plan? Are you able to follow up? Or is there an expert to whom you could refer people? In British Columbia, we developed a special immunization clinic, which is actually a strategy from Australia that extremely hesitants can be referred to for more information, such as assessment of the safety of revaccination after an allergic reaction or other adverse event following immunization. The clinicians there are specialized in vaccination and vaccine research, and they can handle the stumpers that seem to come out of nowhere and exceed regular clinical expertise, such as, why are there cow ingredients in this vaccine? Or how is this kind of aluminum different from the kind of aluminum that's in my tinfoil? These aren't questions that every frontline provider will necessarily have the answers to, and new ones are constantly emerging, particularly as they get spread around on social media. So it's okay if you don't know the answers, but having a way to follow up with parents can be very helpful for sort of shoring up confidence and allaying hesitancy. Another important strategy is to build alliances. So I mentioned that complementary and alternative medicine is relatively common in British Columbia, as it is in many Western settings. Therefore, we recommended building alliances with pro-vaccine practitioners in disciplines such as naturopathic medicine and chiropractic care. Disciplines that sometimes are stigmatized as being anti-vaccine, but certainly have practitioners within the communities who are very evidence-based and pro-vaccine. It's important to keep in mind that what is considered alternative in some communities may be fairly mainstream in others. So, for example, midwifery care is very common in British Columbia. As you can see, over 1 in 5 births in British Columbia are midwife-led. And people really trust their midwives and really like their midwives. However, when we've done research on this, we found that many mothers report that their midwives are reluctant to advise on vaccination, being unsure whether it's within their scope of practice or whether giving their opinion is appropriate. So for public health, to partner with practitioners such as midwives in this setting, or whatever practitioners those might be in your setting, who can really be trusted by the community, and particularly vaccine-hesitant communities, to provide any information they need about vaccines and to provide referral routes for additional information, follow-up for parents can be really helpful. While historically, research and anecdote alike have associated midwifery care and midwives with anti-vaccination attitudes and under-vaccination of clients, the University of British Columbia Midwifery Program has partnered with the Centers for Disease Control to have expert training on immunization integrated now into their midwifery training program with very promising results. In our research, we've heard from midwives who entered this training program very vaccine hesitant, some of whom had chosen not even to vaccinate their own children, and who were completely transformed by this education. It's important to note that such efforts to provide education come against a backdrop of clinical education, which primes students to be more oriented to health equity and other pro-social values, and likely increase the impact of that CDC education. We don't know if the same education session provided to seasoned providers who'd been out of school for a long time would have the same impact. So timing, another element of context, also matters in building these alliances. School-based immunization programs with personal follow-up for parents with questions are convenient and widely accepted in British Columbia. They should ideally be backed up by a personal touch for hesitators who want more information. However, while in-school vaccination increases convenience, local norms are very important to consider in implementing this type of program. In British Columbia, there are fewer barriers to vaccination than in most U.S. settings. Families don't have to provide insurance information for billing, and consent laws allow mature young people to consent to their own vaccines. Because those providing the vaccines in schools are public health nurses, they have the potential to follow up with parents who don't give consent to see if those parents have questions that might be answered with more information about the vaccines. However, even within British Columbia, community norms vary. In considering whether school-based vaccination services are right for a given region, it's important to consider a few things. First, the ability to sustain efforts. Is this a one-off clinic, a catch-up clinic perhaps in response to the measles outbreak, or offering only one vaccine? Or is it able to occur annually and provide catch-ups on a regular basis for any missed vaccination? Another thing to consider is whether insurance or other paperwork will burden parents or discourage certain populations from participating. There's also the issue of consent laws and local norms, even beyond laws, around parental contact and follow-up, around child autonomy, and the trust relationships between local communities and institutions such as schools and the healthcare system. So while in-school vaccination programs can dramatically improve convenience, and help catch people that might fall through the cracks. They also, in many places, need to be implemented with caution due to local norms. Another message that we heard loud and clear in our research is that of the importance of remembering and acknowledging diversity in the population. A powerful strategy to promote vaccination in hesitant groups is to work with culturally specific health promotion groups and patient or parent communities. Culturally specific health promotion programs may have better relationships with some communities than the general medical community does. Build those relationships, even if it takes time, and often it does, and work with those programs to build trust within hesitant communities. Certain immigrant communities may have a lot of vaccine hesitancy. For example, Eastern European regions, some Somali communities, and this combined with lower trust in Western medicine or a lack of regular medical home or primary care provider can lead to non-vaccination. On the other end of things, sometimes we see indigenous communities having suboptimal vaccination rates, which may be related to a lack of trust in government and medical authorities who have historically behaved in some extremely untrustworthy ways, from taking children away from their families and home communities and outlawing traditional practices to confining indigenous patients to segregated medical facilities with subpar care. Efforts to outreach to such communities must be done with delicacy and care, partnering with community leaders, and being mindful of avoiding short-term wins that could turn into long-term stories of betrayal of trust. In our research, we also found parents who are members of GLBTQ communities who have historically been alienated by Western medicine to be at risk for undervaccination due to a lack of trust in healthcare providers. A success story about which you may be aware is that of the 2017 Hennepin County, Minnesota measles outbreak containment. Clinicians from Children's Minnesota and Hennepin County Medical Center worked with a group of 30 imams and mosque executives to promote vaccination and stop the measles outbreak they were experiencing in the Somali community. 13% of Hennepin County, that's the total population is 1.2 million residents, and 13% are immigrants or refugees, and most of those right now are Somali. So the spring 2017 measles outbreak in the region resulted in 70 identified cases, mostly in unvaccinated Somali Minnesotan children. While the overall MMR vaccination rates were 89% in the region, in this Somali immigrant community, the rate was only 42% when this outbreak occurred. According to Elisa Johnson-Aspen of the Hennepin County Public Health Department, outreach to and partnership with Somali Minnesotan community leaders provided the turning point in their measles outbreak. Community leaders did over 150 visits to homes, businesses, community centers, and mosques to provide information and encourage immunization. And after this effort, the MMR vaccination rate in the community saw an 8-fold increase compared with a 3-fold increase in the region overall due to the outbreak. Such communities are often networked in ways that transcend mere geography. For example, the Minneapolis area Somali community reportedly has close ties with Somali communities in Seattle, Washington, Columbus, Ohio, and other regions. So the information that they're sharing may come not geographically local sources, but from culturally near sources. And again, these days, often online. Finally, it's important to remember that not all undervaccination is due to hesitancy. The U.S. Centers for Disease Control and Prevention recently reported that around 7% of uninsured children aged 19 to 35 months were not vaccinated in 2017. 7%. That's compared to 0.8% of privately insured children who were not vaccinated, and 1% of those covered by Medicaid. They also reported that children in rural areas were twice as likely as urban dwellers to be unvaccinated. Even though we have the Vaccines for Children program that is supposed to mitigate a lot of these disparities and provide vaccines for uninsured children, it hasn't fully realized its potential. And whether that's because of other barriers, transportation barriers, for example, whether it's because the message isn't getting out when we ask for insurance coverage to provide a vaccination. It's not always clear that children can get vaccinated even if we don't have insurance coverage, or whether it's because of stigma of not having insurance coverage, or some combination thereof. Poverty, transportation, and other access barriers, as well as lack of insurance, all affect vaccination uptake. So while hesitancy is important to address in all populations, we must also be mindful not to assume that all under-vaccination is due to hesitancy. It's equally important to explore and fix structural barriers in your area. So I'd like to put one more question to you, which is, with this information, how can the vaccine-hesitant populations in your region be reached with confidence-building messages? And who are the potential community allies and partners in this work for you? At this point, I'd like to open it up to your questions, which I'm happy to address, and I understand that we're doing this through the chat box in the lower left-hand corner.
Thank you so much, Dr. Grayson. Yes, please go ahead. If you have any questions for Dr. Grayson, add those to the chat box in the left-hand side. If for whatever reason you think of a question later on, you can feel free to email us at info@immunizednevada.org after the presentation, and we're happy to put those along to Dr. Grayson as well, or do our best to answer them too. Thank you so much for your presentation today, Dr. Grayson. And before we say goodbye and offer a little more time for last-minute questions, we will just remind you of a couple of things. If you've requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended, or in a follow-up post-webinar email. That email will be sent out by the end of today, and all CEUs will be emailed out within the next week. If you'd like to view or share this webinar, the recording will be available on the Immunize Nevada website, along with information for future webinars. Please visit immunizenevada.org/webinars for those details. I'm not seeing any questions in the chat box right now, Dr. Grayson. We'll be sure to pass those along to you after the presentation. There's always a few that come up. If that is it as far as questions go, we'll go ahead and conclude today's NILE webinar. Again, thank you to Dr. Grayson and to those of you who participated, and have a great day.
Thank you, Brian.
Of course.
Thank you. Please stand by.